Good afternoon. So after the talks on weight gain, on weight loss, we're going to talk on about weight gain. As you know, the concept of uh, TB is the highest uh, opportunistic infections in areas for HIV in areas where which is TB endemic, no? Like in the country, as you saw in the Philippines, as you saw earlier, we have a rapidly increasing rates of HIV and the combination, and we're the number 4 in the world amongst the highest rates of incident TB. So the combination is tragic, no? So this concept of the post-TB lung disease we all know of this. We know that there are chronic changes and irreversible changes post-TB, but me as an infectious disease specialist, my concern was just sputum conversion. Once they're treated, we follow them for 2 years just to check that they have no relapse, but we don't really check for the post-TB complications. We were happy if the sputum are negative and the sputum cultures are negative, and then we let them graduate 2 years after. So, and not looking at the other aspects of post-TB disease, where they could barely find work because of their shortness of breath or chronic cough. So this is a new and not a new concept, but it has been looked into deeply in the past 3 to 5 years. And in fact, the post-TB lung symposium will just be on its 3rd round this year. It will be held in Cape Town. So I will start with a case that you probably have seen in your clinic. This is one of my cases and a recent case. So he's a young 36-year-old man with a BMI of 20 in July. That's July 2023. So he came in July with dyspnea and chest pain. And the patient was a previous patient already. He's a clinical trial patient. He was previously treated in 2010 for DSTB, and he completed an MDR-TB treatment in 2022. So he completed a 9-month regimen in 2022 and was declared cured, but cough and episodes of shortness of breath did not resolve. So there was a recurrence of TB in July of 2023. Hence, we enrolled him in a clinical trial for an FQ resistant TB. So he presented for this in the hospital on the month 12 of his treatment, and we had to admit because he had difficulty in breathing, no? Previous to that, even after a sputum conversion, on month 3, he had several admissions and for pneumonia and COPD exacerbation. So consider that he was also a smoker who just quit just before this recent diagnosis. So this was his baseline X-ray. So the X-ray revealed fibrowaste and fibronodular densities in both lungs with varied sizes of cavities in the upper lobes and there are bilateral apical pleural thickening. So it's a combination of a chronic as well as active lesions, no? 1 month after, we did a CT scan because he had fevers and had exacerbation of difficulty in breathing, so we had to admit him. So that was his first admission during this treatment, and this is the CT scan, which showed fibrotic densities admixed with several thick-walled cavitations. There are bullae formations, and there's some consolidation in the lower lung. So because of his shortness of breath and COPD symptoms, we had put him even initially on long-acting beta agonist and long-acting and LAMAs, long-acting muscarinic antagonists. And he had been okay with those. He has been functional, basically functional with those. But in 6 months post-treatment, the lung symptoms was progressive. So we did a lung function test, which showed a severe obstructive signs with an FEV of 1 of 25% and FVC of 42%. There is reduced lung expansion and mild restriction, and there is the RVs was 180%, and there was chronic. There was a large retention, air retention, and the DCLO was very severe. Oh, sorry. Was very low at only 18%. So there was a very low diffusion, lung diffusion. So I start with the question, which of the following is the least likely explanation for these ongoing symptoms? A, is it post-TB lung disease? B, drug-resistant treatment failure, bronchiectasis, or MI? So, of course, since we're in a post-TB complications, so it's likely PTLD, no, or bronchiectasis, because he had a lot of bronchiectatic changes in his CT scan, and we did a 2D echo as well. It showed a very severe pulmonary hypertension. So this patient actually died in his last admission in July of 2024 because of CO2 retention. So we go back to the lung anatomy. I feel like a fraud here as an infectious disease discussing about lung. So Dr. Manun should be the one doing this for us. So anyway, as you know, this is the lung would be consisting of your airways, and then the lung exchange, air exchange would happen in the alveoli. So there's a vast surface for gas exchange provided by the millions of the alveoli, And this is just the last picture here. It's just an EM of a cross-section of the alveolar wall and a lung capillary. So airway diseases, your asthma, your COPD, or bronchiectasis are airway diseases, and interstitial lung disease are basically an alveolar disease, no, parenchymal disease. So what happens in TB? So with TB, if there's a failure of your adaptive immunity and the patient will have TB, the lung pathology would be a primary inflammation, interstitial infiltration, tissue hypersensitivity. There's a lot of castration and necrosis, and with healing, there would be fibrosis and calcification. So you could somehow extrapolate that among patients with HIV, there would be, because the inflammation from HIV and the inflammation from TB itself would be cumulative, no? So you could say there's no data yet, but you could hypothesize that patients with HIV and TB would have more probably post-TB lung disease. So the permanent lung injury due to TB is frequent and substantial. There are several cohorts that show this. Even after completion of TB treatment, residual changes remain, which may affect the quality of life of patients. So in a Papua New Guinea cohort, the FEV1 of patients on TB diagnosis was reduced by 64% compared to healthy cohorts. And improvement in FEV1 was only 11% after 2 months, with no further improvement thereafter. 27% had moderate to severe pulmonary function impairment after treatment. And in India, a cohort showed that the severe irreversible obstructive pulmonary ventilation defect affects a third of patients 1 year after after treatment. And in Pakistan, 155 adult patients who completed TB treatment, 11%, 9% or 11 had complete resolution. Only 9% or only 11 of the 155 had resolution of the disease, complete resolution of the disease with no pulmonary changes, and 91% developed post-treatment parenchymal and pleural sequelae. So the complications of TB after treatment completion can often be misinterpreted for other active diseases, which is why we now have the concept of clinically diagnosed TB. And if you look closely into it, probably most of these cases are just patients with post-TB lung disease. Radiologic assessment is key in recognizing and understanding the manifestation of the thoracic sequelae, and post-TB sequelae can be categorized into either parenchymal, airway disease, pleural or chest wall, vascular and mediastinal pathology. So the spectrum of damage is wide, and so they can present with obstructive, restrictive, and mainly the most common is bronchiectatic changes. These residual changes can be minor, however, some can be debilitating and even fatal. So these are just some of the categories of the post-TB sequelae. So for parenchymal, you have the tuberculoma, you have a thick-walled cavity that does not resolve, cicatrization, collapse, aspergilloma, bronchogenic carcinoma. For airway disease, you have the bronchiectasis, tracheobronchial stenosis, bronchiolithiasis. For pleural, you have the empyema, fibrothorax, bronchopleural fistula, pneumothorax. For vascular, you have the Rasmussen aneurysm, enteritis, and thrombosis, dilated bronchial arteries. For mediastinal, you have calcified lymph nodes, fibrosing mediastinitis, and pericardial TB. So tuberculomas is you see this commonly in your clinic. They ask for clearance for work for their regular x-ray findings. And it can either be primary or post-primary. It's usually manifests as a rounded soft tissue density, usually seen, better visualized on CT. It usually has a smooth margin with calcification. Now, the cicatrization collapse results from a combination of parenchymal and airway involvement. This is what is seen in this picture. There's a collapse of the whole of left lung. It can be part of or whole of the lung, completely destructs the resulting cavitation, which can end in debilitating fibrosis. There is an area of alveolar destruction with loss of lung volume and ipsilateral mediastinal shift. More often, it's unilateral, and once the lung is destroyed, it is hard to rule out active disease on imaging alone. Sometimes even gene expert can be positive for these cases for a long time, which just shows dead bacilli. So tracheobronchial stenosis, I just realized from my reading is a very common phenomenon. It's the most common cause. Post-TB tracheobronchial stenosis is the most common cause of benign tracheobronchial stenosis. It is caused by the granulomatous changes in the tracheobronchial wall or extrinsic pressure from enlarged peribronchial lymph nodes, which may start as simple edema and subsequently progress to fibrosis with narrowing of your tracheobronchial diameter. The left main bronchus is more frequently affected, and there is wall thickening enhancement and enlarged adjacent mediastinal nodes, which is commonly seen on the CT scan. Management is usually by balloon dilatation, but if not resolved, the use of stenting or self-expandable metallic stent has been useful. No? So aspergilloma is another common phenomenon that we see in our clinics. The residual tuberculous cavities post-treatment results in colonization of superadded organisms such as a fungal ball. No? Cavities which are more than 2 cm after treatment has a 20% chance of developing aspergilloma. This presents in CT as an air crescent sign with a soft tissue density in the cavity that moves with change in body position. So most of the time it's asymptomatic or present with hemoptysis. So the mortality is 20 to 33% over short term, but it can go up to 80% within 5 years. The best diagnostic tool is an antibody test, serum galactomannan. It can be treated with VORI, isobuconazole, itraconazole for 4 to 6 months, but the definitive management for a severe hemoptysis could be surgery, lobectomy of that lobe and or embolization. So bronchiectasis, on the other hand, occurs due to destruction and fibrosis of the lung parenchyma with irreversible secondary bronchial dilatation. It may occur during active TB treatment, but it can also, most of the time, it develops as a sequelae of TB. So in a systematic review of 27 studies, 35 to 86% of patients had bronchiectasis after TB recovery. These most frequently, post-TB bronchiectasis most frequently affect the apical and posterior segments of the upper lobe. And recurrent infections, progressive deteriorating lung function, reduced exercise tolerance, and reduced quality of life is very common amongst patients with bronchiectasis, and they would present with chronic cough, with hemoptysis, and recurrent bacterial infections. So this picture, a CT picture on the right is a normal lung, but this one in the left shows the lung with bronchiectatic changes. No, the recurrent lung infections results from a structural damage, persistent inflammation, mucociliary insufficiency, and bacterial and fungal colonization. The most common infectious agents seen, because they're the non-cystic fibrosis infections. It's also somehow the bacterial pathogens are similar to cystic fibrosis, where you have Pseudomonas aeruginosa, H. flu, Moraxella, staph, and recently there's more and more cases with Burkholderia, Cepacia complex, or steno, Trophomonas, and other members of the Pseudomonadaceae family. So NTMs are commonly isolated in bronchiectatic patients with infectious exacerbations. So I have been in managing MDR-TB since 2001, no? And we would see NTM during the course of the treatment, especially in the maintenance phase, and we would just say those are contaminant, these are not significant. But actually, there's these patients with a bad lung should be treated for their NTM, because we would see similar organism monthly, NTMs monthly. So the management mainly is pulmonary rehabilitation for airway clearance through chest physiotherapy, inhaled hypertonic saline, exercises if indicated, aimed at reducing the frequency and severity of your recurrent infections, improving exercise tolerance and quality of life. And the data on long-term antibiotics for prophylaxis is somehow controversial because it can also lead to resistant organisms. If the disease is local, surgical resection can be done. So pleural complications are empyema, which is a persistent purulent fluid caused by a rupture of your subpleural caseous focus, which may be seen in the pleural space even after bacteriological cure. And this fluid is difficult to culture. CT would include nodular, thickened, and enhancing pleura with high density pleural fluid. And you also have your chyliform effusion, also known as post-TB pleural complication. The CT findings would include fat fluid or fat calcium level in the pleural cavity. So the role of pulmonary rehabilitation in any lung disease is very significant, but access to pulmonary rehabilitation is not available to most patients. Like for our facility, it's expensive, so patients cannot really avail of it. And the the rehabilitation basically improves the quality of life of these patients. So other significant management are seasonal flu vaccination to ensure that there's no secondary bacterial infection after a flu bout, and smoking cessation should be overemphasized. Most TB programs now include a smoking cessation program, integrate the smoking cessation program, but it's not really that well implemented. So countries should start implementing smoking cessation in the TB program. Other potential interventions are, so this is a randomized clinical trial of adding metformin into TB treatment. So as an adjuvant to TB treatment, metformin was given for 500 mg for 7 days and 1,000 mg for 7 weeks. There was no difference in culture conversion, but there was diminished excess inflammation. As you see here, the inflammatory markers was significantly decreased after week 8 of treatment. The CRP, the interferon gamma, and your TNF significantly decreased with after 8 weeks of treatment. So, which could mean that metformin could probably, if given as an adjuvant treatment, could probably decrease the probability of post-TB complication or post-TB sequelae. But this has to be looked into still. So in summary, the awareness of post-TB lung health is increasingly important and gaining more attention. End of treatment spirometry, sputum AFB, screening for aspergillus, chest x-ray may be helpful in assessing a patient after treatment for TB, and they subsequently present with a potential relapse and non-specific infection or other sequelae. So smoking cessation, vaccination, preventive antibiotics, and pulmonary rehabilitation may help curb exacerbations and reduce lung function decline and eventually improve quality of life. And this is my last slide. Thank you.